We would always, I can remember talking with you a lot about this, that they should, talking about the fact that the emphasis almost, so, you take the DNS courses, or we talk about this stuff, and we emphasize kind of the muscular effort strategy of bracing
Mm,
and
mm,
breathing.
mm,
But we would also say that we should rename these courses support point,
mhm,
because the emphasis should be at least even on, we need to emphasize where the support points are and that the patient is aware of those support points,
mhm,
because that is the way the central nervous system reflexively integrates the muscle pattern that we are trying to voluntarily overdo in the initial
mhm.
training. So
Exactly.
it's not that, I mean, obviously there's a certain amount of cortical function of, I'm going to try to brace and breathe, and I'm going to pay attention to it and create this pressure and create this muscle tension. But
Mhm,
like you said, if I don't have adequate support through the major support points for particular postures, ultimately there is no way to reflexively integrate any kind of
mhm,
stability
mhm,
pattern. There just
mhm,
isn't. So it's, you can cortically think about it all you like, but the cortical thinking about it only gets you so far. It's, your medial epicondyle needs to be felt into the ground so that
mhm,
your brain gets that information and can then reflexively integrate
mhm,
the pattern, and you don't have to
mhm.
think about it anymore.
Yeah.
And for your patient who walks on the outside of his foot, there is no amount of cortical activity, muscle strengthening, that is going to override the fact that poor information is coming from a
Mhm.
foot that is being supported only in the lateral column. They
That's right.
need the sensory information coming from all the major supports of the foot
Mhm.
in order to actually reflexively integrate it into the system. And then you don't have to think
And
about it anymore.
no,
The thinking
and
about
it's
it is the, do I feel support through
that's
those
right.
places?
That's
that's
what is
that's what I'm thinking
important.
about.
That's it. So, and again, as we have talked about, you will have to kind of examine the subsystems that are involved in bringing better support to the foot. For example, it may be that the person has a vision problem, and therefore where he thinks is neutral is not, and so he shifts over to one more to one side, to the left or the right, and causes this aberrance in support points.
Hmm.
Or he may have a vestibular problem, and that also causes it. Or he has a proprioceptive problem, or he has weakness in the muscles and he can no longer support himself on the ideal support points because they have informed him that they are not adequate to the task, and he
Yeah.
subconsciously is aware of that. So again, you cannot just push somebody over from left to right or right to left and force him to now undertake a new position without making sure that the resources are there for him to actually assume a new position. Otherwise, it will be a long and fruitless fight, because the brain, as we say, must receive the kind of afferent stimulus that allows it to make a new decision about the position of the foot. It cannot, you cannot change the foot position without changing the information that should help the brain to form that new position of the foot.
Right. Right. And I guess, well, maybe not moving from there, but
Mm,
that kind of bleeds into when you and I kind of get past the initial kind of screening and assessment procedures of, is there any true kind of distortion in the spine, in the hips and the shoulders. People seem to be able to generate intra-abdominal pressure and sagittal stability. At
mhm,
that point, you can start to kind of if the patient's shoulder still hurts at that point, or their ankle still hurts, you can do some local things to try to desensitize those regions.
Mhm.
But after that, you can start to then test, well, how well can this patient coordinate muscle activity across the body?
Mhm.
Whether that's a little bit more proximally in the oblique chains, from a shoulder to a hip, or the oblique chains from the hand all the way down to the foot.
Yes.
And you and I uh, test these things or screen for these things, and
Mhm.
we just generally call them like provocative chain tests. We are
Yes.
provoking the muscle chains in a variety of ways, in a variety of positions, to see
Mhm.
how patent they are.
Yes.
Maybe you can talk a little bit more about that.
Well, yes. When I was challenged by deciding what exercise to give my patients, it became imperative that I gather more information so that the exercise could be tailored towards actually restoring some deficit rather than a general strengthening exercise in the hope that the patient would benefit from it.
This is the age-old DNS question. I mean, you take a DNS seminar, and at the end of it, most people ask, "Okay, well, when do
What?
I use
That's
this
right.
one exercise?
When do I
Why
use
would I
this
use this
position?
other one? Why would I use the different position?"
That's right.
And generally, we would say, well, in general, you can stick with the developmental process.
Yes.
Begin with the early positions, and as they master those, you move through the developmental
Hmm.
process. And that certainly makes a certain amount of sense, and you can
Hmm.
get away with that, and it's perfectly
Hmm.
fine. And that's a
Hmm.
lot of the time what most people do.
Yes.
But, like you said,
Right.
if you want to hone the skill a little
Yes.
bit,
I wanted to hone my exercise choice, and I wanted to have some way of assessing the effect of the exercise because it would, being out of pain is not a criteria of success. It is just that you are successful in getting the patient out of pain. So if the patient is now not having pain, what are my other measuring tools? What are my other baseline measurement tools that I can use to assess the efficacy of the exercise I've given, or decide that there's a better exercise than the one I have given, etc. So it became obvious that one would have to test strength not only in individual muscles, but also in how the brain utilized chains of muscles, because this is how it works. And
this is how
sometimes
the muscles actually
that's
function
actually
versus.
how they function. They function in chains, they function in loops, they function in arcs. Nobody moves one muscle at a time. It just does not happen.
And
So,
then the further tricky part is, even if these chains are functioning, depending on where the body is weight bearing and supporting, the chains function in a little bit different
may be
ways than.
compromised.
Right.
Exactly. So we had to come up with a battery of tests that would challenge the chains and the muscle loops and arcs in different functional positions that were scattered throughout the three cardinal planes. The in this way you could then find out if there was a particular weakness of a certain chain, whether it is part of the lateral chain, the sagittal chain, the oblique chains, or the transverse chains. You could then assess them, and by testing their integrity, you could decide which ones could be ignored and focus on the ones that showed dysfunction. And the thing is this, like anything, there are two aspects. You may have a chain whose components are are working well, but the brain does not know how to link them up into one continuous functioning um, chain,
Yeah. So
really.
what you're saying, I mean, when you say that, essentially, I think what you're saying is when you say you have components that are working well, but ultimately the
Hmm.
brain can't link them up. Just to give a practical example, there's a posterior oblique sling of
Hmm.
muscles that some of
Hmm.
the muscles, you might say glute medius or
Hmm.
glute maximus,
Hmm.
with the opposite lat, with the
Hmm.
particular muscles. And if you were to isolate and test these individual muscles, they
Hmm.
might in fact be generally strong.
That's
But
right.
then when you actually utilize or test someone in a particular posture that requires the chain of those muscles, they fail.
Yes, right.
And
So,
that's where
yeah.
the problem
And
comes in.
that's where the problem comes in. So it's one thing when you have aberrant muscle function within individual muscles of the chain. Then you treat that and you retest the chain. But when you have no aberrant muscle function, but the chain still cannot be used, you still have to have a way of encouraging the patient to to feel, to perceive the chain, to have aesthesis, incoming sensory afference of what the chain feels like, so that he can manipulate it and use it to his advantage. Otherwise, the person has no comprehension of the chain. He may feel parts of it, but he doesn't feel the whole effect. And it renders the chain useless in especially when it is being loaded significantly. Luckily for us, we have the ability to leverage forces of alternative synergies. So we can substitute for loss quite well. But if we run out of these options, then we're in real trouble or we get injured quite rapidly.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.